welcome to our video on pain syndromes. Let's get started. Here's an overview of what we'll be discussing in this lecture. Let's start with polymyalgia rheumatica. And here's a list of topics that we will be discussing for polymyalgia rheumatica specifically. So we're going to start with the definition of that. Polymyalgia rheumatica is an inflammatory rheumatic disease that has a typical presentation and mainly affects elderly patients. And it's also important to know that females are 3 times more affected than males. Now, elderly female patients are mostly affected with a peak incidence in patients who are more than 70. Polymyalgia rheumatica is thought to be more prevalent in patients of Northern European descent. Now, genetic associations have been described, but it's really rare to find a genetic association. Now, the most high-yield association that you need to know for the boards is its association with giant cell arteritis. That's a large vessel vasculitis. Now, we discussed giant cell arteritis in another lecture, so make sure to check out our video on that for more information. The pathogenesis of polymyalgia rheumatica is not exactly known, so it's idiopathic, although an autoimmune disease process has been proposed. It is thought that this condition occurs as a result of a multifactorial process of genetic and environmental factors, both playing a role. An association with HLA-DR4 has been especially described. And as a result, inflammation is that as a result of this genetic variation, inflammation will affect the bursae, joints, and tendons. And this inflammation leads to referred widespread body aches and the pain that the patients experience. Patients experience a combination of musculoskeletal and systemic symptoms. Musculoskeletal symptoms present as bilateral muscle pain affecting the neck, shoulders, and hips. And patients will complain of limited active shoulder abduction. They're not able to lift their arm up as much, and hip and groin pain, and that pain is typically worse at night. There's also associated morning stiffness due to the synovitis that can be severe and limit activities of daily living, abbreviated ADLs. Patients can also experience systemic symptoms, namely B symptoms, such as fever, chills, and malaise. Now, anorexia and weight loss can also be evident. And here's an image that shows the classical locations affected in polymyalgia rheumatica. These include the shoulders bilaterally and the pelvis or the hips. Polymyalgia rheumatica can be essentially diagnosed clinically with laboratory evaluations supporting the diagnosis. So think about what they're actually presenting with and what they describe to you. Patients classically report morning pain and stiffness, and that typically lasts for more than 45 minutes. And the physical exam will reveal limited range of motion, particularly in the shoulder joint. So especially ask about that. Now, patients won't be able to abduct their shoulders more than 90 degrees. And also, you might see joint swelling. Laboratory tests can be all normal. So that's why we say you actually really get the clinical diagnosis with some support from labs. Now, often on a complete blood count or CBC, you might see normocytic anemia. Now, it's important to note that the serum creatine kinase, CK, will be normal. And that's actually really helpful because it can help you distinguish this condition, polymyalgia rheumatica, from other types of myopathies. Inflammatory markers are often elevated, such as the erythrocyte sedimentation rate, or ESR, the C-reactive protein, and you might see leukocytosis. Polymyalgia rheumatica is managed with a low dose of corticosteroids. Usually it's prednisone, and you give it orally. And it's tapered down with improvement of the symptoms. So as they start getting better, you start tapering them off. Now, the disease is usually self-limited and doesn't require treatment, so it just resolves on its own. But patients should be monitored in case they develop symptoms of giant cell arteritis. Remember, we talked about how important that association is. Some of those symptoms they may have that might make you think of giant cell arteritis are temporal headaches and vision loss. In those cases, you need to use high-dose steroids and do that IV. Let's do a question to apply what you've learned. A 78-year-old woman comes to the physician due to a 5-month history of fatigue and weight loss. She also reports stiffness that is predominantly present in the morning, as well as pain in her shoulders and hips. Her temperature is 38.4 degrees Celsius, which is 101 Fahrenheit. Physical exam shows symmetrical limited range of motion at the shoulder and hip joints. Laboratory tests show an elevated CRP and erythrocyte sedimentation rate. What condition is highly associated with this patient's disease? All right, so this elderly female patient most likely has polymyalgia rheumatica, and it classically presents with shoulder and hip pain, as well as morning stiffness that's symmetrical, and there's also limited range of motion. And she fits that description. Now, nonspecific symptoms include fatigue, weight loss, and fever. And lab tests commonly show an elevated CRP and ESR. And it's very important to remember the high yield association between polymyalgia rheumatica and the large vessel vasculitis, giant cell arteritis, or temporal arteritis. And it's so important that we wanted to reinforce it with a question right here. So patients should be asked whether they've had new headaches, jaw claudications, or vision changes, as a timely diagnosis and management of this disease is essential for better outcomes. So again, if they present with polymyalgia rheumatica, think about giant cell arteritis. Now let's discuss fibromyalgia. Here's a list of topics that we'll be discussing for fibromyalgia. Let's start with the definition. Fibromyalgia is considered to be a musculoskeletal disorder characterized by a widespread and chronic pain. Now, females are affected twice as males. Similar to polymyalgia rheumatica, which had a 3-to-1 ratio, this one has a female to male ratio of 2-to-1. So still heavier on the female side. The exact etiology and pathophysiology of fibromyalgia is still unknown. It's thought that multifactorial issues such as genetic and environmental triggers can play a role. Now, dysregulation of pain perception has also been proposed as a mechanism, as some research showed evidence of a heightened pain response to painful stimuli. Now, fibromyalgia is often associated with psychiatric disorders, such as depression and anxiety. The main clinical presentation of fibromyalgia is the widespread and chronic body pains that are constant and dull in nature. This can be accompanied by stiffness that is mostly present in the morning. Associated symptoms frequently include disturbances in sleep, fatigue, and cognitive as well as psychiatric disturbances. Now, those cognitive disturbances, referred to as fibrofog, you might hear, describe symptoms such as difficulty concentrating, lack of clarity of thought, and memory problems. And it's often reported by patients with fibromyalgia. They've got this foggy brain, so we call it a fibrofog. Now, fibromyalgia is definitely a clinical diagnosis, and you suspect it in patients who have had pain for more than 3 months, and they have no other identifiable cause. So really, you're just ruling out anything else. It's a diagnosis of exclusion. Now, on physical exam, the classical points on the body may be tender or trigger pain. Those are called trigger points. And those areas you want to be thinking of are the shoulders, the buttocks, and the upper chest. Here's an image that shows the trigger points that are reported in fibromyalgia. These include the mid-trapezius muscle, lateral epicondyle, costochondral junction, and greater trochanter. You don't need to memorize all of these trigger points, but you'll need to recognize when the question stem is describing the presence of a trigger point or a tender point. So as you can see, there's several pressure points, and they're all really consolidated around the upper chest and the buttocks and the neck. But there's also the elbows and knees. It's important to note that labs and imaging are all normal in fibromyalgia, as we said before. So you're just trying to exclude other diseases. So would it make sense to get labs? Yes, it would, because you don't want to miss another disease that you could catch with labs. So with fibromyalgia, you're doing these labs and you're expecting them to come out normal. And if they are, then that helps support your diagnosis. Patients with fibromyalgia need to be educated about their condition. Confirming that it's a real condition and that it's not in the patient's head is also an important step. Now, relaxation and exercise techniques can be recommended, and those things can improve pain and fatigue. However, exercise may actually acutely exacerbate the symptoms in some patients. Now, low-dose TCAs, tricyclic antidepressants, such as amitriptyline, is initially used as a drug. If there's no improvement of symptoms or for severe symptoms, SNRIs, such as duloxetine, can be used. There's also some anticonvulsants you can use, such as pregabalin and gabapentin. So in essence, when you're managing this, it's all about educating them and then starting with low-dose TCAs and duloxetine and maybe some anticonvulsants. Now let's do another application question. A 35-year-old woman comes to the physician due to 4-month history of recurrent episodes of generalized body pains. She also reports having difficulties getting restful sleep and lately has trouble concentrating. Physical exam reveals marked tenderness in the posterior neck, mid-trapezius, and lateral epicondyles bilaterally. What would lab tests show for serum CK and erythrocyte sedimentation rate? Okay, so this middle-aged patient most likely has fibromyalgia. And recall that females are 2 times more likely to have this than males. And the chronic history of generalized body pains and the presence of tender points on physical exam here are all classical features of fibromyalgia. Remember that in fibromyalgia, all laboratory tests should be normal. Therefore, the serum CK and ESR will both be normal, which can help you distinguish this from other myopathies and pain syndromes. All right, next let's discuss complex regional pain syndrome. Here's a list of topics that we'll be discussing for complex regional pain syndrome. Let's start with definition. Complex regional pain syndrome is a syndrome that describes the pain and the associated sensory and autonomic changes involving a body region. Now, such changes are described as regional and out of proportion to the inciting event, and usually a trauma. And it's usually localized to distal limbs. And once again, females are more affected than males. The exact pathophysiology is unknown. An inciting event, usually trauma, such as fractures, sprains, and surgery, which then cause inflammation and hypersensitization of pain receptors, eventually lead to dysregulation of pain perception in the central nervous system. At least that's what's been proposed. But again, the exact mechanism is not known yet. Now, it's important to note that in complex regional pain syndrome, there is no acute nerve injury, even though they do have these sensory disturbances, possibly due to trauma. Patients usually present with pain that is out of proportion to the initial event, that proposed traumatic event that we were discussing before. In fact, it's longer and more severe, and patients complain of burning or stinging sensation that's worse at night and worse with movements. Usually those symptoms start 4 to 6 weeks after the inciting event. And sensory symptoms, such as hyperesthesia, which is the increased sensitivity in the affected limb, as well as allodynia, which is pain in response to a stimuli that under normal circumstances wouldn't cause pain. So they're having pain and you're kind of surprised that that hurt them. Autonomic changes, such as hypo or hyperthermia, as well as color changes, or even atrophy of affected limbs, can all be presenting symptoms of this syndrome. Other symptoms include swelling, limited range of motion, as well as changes in hair and nail growth. This is an image of a 60-year-old male patient with complex regional pain syndrome after a left tibial fracture. Now, this is the affected leg. Notice the swelling and hyperpigmentation that is present here in comparison to the normal leg on the right. Just like fibromyalgia, complex regional pain syndrome is a clinical diagnosis, so it should be suspected in patients with a history of trauma, and that this pain or this syndrome really presents to you within 4 to 6 weeks after that trauma. And again, think about pain out of proportion to that initial injury. Interestingly, the symptoms do not have a dermatomal distribution. It's non-dermatomal, and it can actually extend beyond the initial affected area of the trauma. Bone imaging is sometimes performed to make sure that the initial trauma has healed properly, which makes sense. You're going to want to make sure that the patient doesn't actually have some severe trauma that hasn't been addressed or healed before you diagnose them with complex regional pain syndrome. But once you've ruled that out, an X-ray may show some patchy areas of osteoporosis and osteopenia. Now, bone scintigraphy also may show areas of increased metabolism. And just like fibromyalgia, which is a clinical diagnosis, you want to make sure you exclude other causes, such as infection or neuropathy. Now, management of complex regional pain syndrome requires a multidisciplinary approach. So, once again, patient education is very important. Physicians need to emphasize the importance of working towards regaining limb function. You want to help them get their strength back. And the role of physical and occupational therapy then becomes essential, and it's in fact considered as a first-line treatment. And once you've educated them and you've employed PT and OT, you can start thinking about meds such as NSAIDs, anticonvulsants, such as gabapentin, or even you can use TCAs like in fibromyalgia. And again, the goal for all of these is to control pain. Now let's do one board-style question to apply what you've learned. A 34-year-old woman comes to the physician due to a 4-month history of episodes of severe pain affecting her neck and shoulders and knees. The pain is exacerbated by exercise. She has a history of depression and suffers from chronic tension headaches that she takes over-the-counter painkillers for. On physical exam, palpation of the neck, shoulders, and knees elicit pain. The rest of the exam, including muscle strength and deep tendon reflexes, are normal. Her temperature is 37.4 degrees Celsius, pulse is 74 beats per minute, and blood pressure is 134 over 83 millimeters of mercury. laboratory tests show a serum creatine kinase of 50, normal being between 10 and 70, and an erythrocyte sedimentation rate of 7, normal being between 0 and 20. What is the best initial treatment for this patient's condition? A. Low-dose oral prednisone. B. High-dose systemic glucocorticoids. C. Observation. D. Low-dose tricyclic antidepressant. Or E. Gabapentin. So from this question, this middle-aged woman is presenting with chronic pain and multiple tender points on her neck, shoulders, and knees. Everything else is normal, including her lab results, having a normal ESR and normal CK. This patient, therefore, most likely has fibromyalgia, and the best initial treatment is a low-dose tricyclic antidepressant, option D. Remember that fibromyalgia is a clinical diagnosis, and it's diagnosed in patients with pain that persists for 3 months or more without any other identifiable cause. And they have those trigger points. They often present on palpation during the physical exam. And most importantly, all laboratory examinations should be normal, which sets this disease apart from other myopathies and pain syndromes. Now, option A is incorrect because low-dose oral prednisone is the treatment for polymyalgia rheumatica. And polymyalgia rheumatica really isn't consistent with this 34-year-old patient's presentation. Remember, tender points you wouldn't expect in polymyalgia rheumatica, and you would expect some elevated inflammatory markers. But they're not. They're normal in this case. Now, option B is incorrect because high-dose systemic glucocorticoids is the treatment for giant cell arteritis. Now, giant cell arteritis mostly affects the elderly and classically presents with a temporal headache and jaw claudications and visual deficits. Those are all absent in her. And again, the association there is with polymyalgia rheumatica. You wouldn't really expect giant cell arteritis in a patient with fibromyalgia. Now, option C is incorrect because even though low-dose TCAs are not curative, which is what we chose, option D, they do help manage the symptoms of fibromyalgia. Therefore, only observation is not sufficient. Now, option E, gabapentin, is incorrect, as anticonvulsants aren't used as an initial treatment for fibromyalgia. So again, the correct answer is D, a low-dose tricyclic antidepressant. And that concludes this section.